It's really up to us with with looking at the research and seeing that it works and speaking to our colleagues, teaching our colleagues that it can be used.
You're listening to In Your Pants with Dr. Susie G, the physiotherapist for your private, helping you get in the know, down below.
Hey friends, Dr. Susie G here, and welcome to another In Your Pants podcast. 1 in every 3 women and 1 in every 20 men will experience the effects of urinary incontinence. Now, those are pretty alarming numbers. The good news is that there's hope and that there's help. So on today's show, my guests and I talk about urinary incontinence and urinary urgency and frequency, overactive bladder, and some conservative treatment options that are not talked about in the medical community. We are going to be talking about transcutaneous tibial nerve stimulation. And my guest is going to help us understand what that treatment option entails and how you can feel empowered to take control of your bladder symptoms today. To formally introduce my guest today, her name is Fiona Rogers. Fiona graduated with her Bachelor of Physiotherapy from the University of Queensland in 1984 and Postgraduate Diploma of Exercise and Sports Science from Sydney University in 1988. She has worked in many settings across the public and private sectors, including the Defense Force and as a clinical supervisor of physiotherapy students. Following the births of her 2 girls, Fiona had the opportunity to move into pelvic health and has spent the last 25 years working exclusively in the area. For much of that time, she was a partner in a very large private practice group on the Sunshine Coast, Australia, establishing the Women's Health Service and mentoring all new staff. For the past 10 years, Fiona and her husband have owned the website Pelvic Floor Exercise, Australia's only boutique source of products for pelvic floor rehabilitation, servicing hospitals, private practices, and customers. Through the website, Fiona also provides resources and education for patients and health professionals. In 2019, she developed her first advanced level course for health professionals on neuromodulation for pelvic health, which she has presented around Australia and, thanks to COVID, converted to an online format. She has since released a course on transcutaneous tibial nerve stimulation and recently had a scoping review paper published on this topic. Fiona teaches for the APA on their WMPH pathway and is frequently asked to speak on topics of products and neuromodulation for pelvic floor conditions in Australia, overseas, and at medical conferences. This episode is jam-packed with practical information and knowledge to empower you to take control of your bladder concerns. So, without further ado, let me introduce Fiona Rogers. I hope you enjoy the show. Hi, Fiona. Thank you so much for being on the show today.
Hi, Susie. Thanks so much for having me.
Well, I'm so happy to be talking about this particular unique treatment option that we have for bladder concerns because in the United States alone, it has been said that over 25 million people experience urinary incontinence. That's a lot of people. I'm not sure what the stats are in Australia, but certainly a huge impact on people's lives. I'd love to just talk about that,
I think statistically they're similar across the world. Obviously, our population is less, but the stats are very similar. And it's basically a quality of life issue because if you're suffering from urinary urge incontinence, which is what we're sort of talking about here is, people become very isolated. They're worried about leaving home in case they have an accident. And, I've treated many people over the years who literally have stayed at home and put themselves into self-isolation, which we're all quite used to now, having gone through the pandemic. But it's a very, very isolating, and financially it can be very difficult for people as well, because the cost of using pads and treatments and so forth. So it's a difficult condition to treat for a lot of people.
Absolutely. And not to mention just overall body image and self-esteem when it comes to sexual intimacy of,
Absolutely.
dealing with bladder concerns, for sure. For sure.
And people will avoid lots of activities, like sex and exercise, all the sorts of things that are fun in life. People will tend to avoid for fear of having an accident.
Right, exactly. And we're here, you and I are here having this conversation because there's hope and there's help for urinary incontinence, for bladder urgency and frequency, overactive bladder. And you recently have, with your colleagues, written a paper or published a paper called Transcutaneous Tibial Nerve Stimulation in the Management of Overactive Bladder Scoping Review. So I just wanted to shout out that paper because it's not easy to do research. So kudos to you and your team for putting together this wonderful review. And that's what we're going to be talking about today is what conservative treatment options, particularly the TENS, transelectrical nerve stimulation, how that is really not talked about or offered as a treatment option, at least in the traditional medical sense, in the medical community. It's not one that's really offered as or known as a treatment option. And I don't think that the consumers know how effective this treatment option can be. So, Fiona, can you tell us what TENS is and what it isn't, and how it might be helpful for things such as urinary incontinence or urgency and frequency? Yeah.
I'll just firstly, can I say it's possibly because a lot of medical professionals aren't aware of it or its efficacy as well. And TENS has always been left as a last resort. But the research is starting to show us that it should be more one of the first line treatments. And basically, it's just using a TENS machine with little nerve pulses that in very lay terms, it has a calming effect on the nerves. So we're putting a different input into the nerves to get a different output. So it calms the neural pathways down, and we use it for the bladder. We can put it along the nerve pathways that affect the bladder. And the easiest way to do that is with what we call transcutaneous tibial nerve stimulation. So all that big mouthful means is using it through the skin, which is transcutaneously, and we're putting it over the tibial nerve. And the tibial nerve actually sits around that little lumpy bit on the inside of your ankle. So it's a nerve that then branches up through the back of the leg and into the sacral area of the spine. And it's that's one of the nerve pathways that affects the bladder control. So, and particularly the sensation of the bladder. So if we put that different input with it's a tingly sensation. If anyone has ever used a TENS machine, it's actually quite a nice feeling. It's a tingly, pins and needly type sensation. It's going through that nerve to the same pathways that affect the bladder, and that can have a very calming effect on the bladder. The other way we can use it is putting it across the sacrum, so through the tailbone area, and will have a similar effect. But the research and what we did our paper on is showing us that using it on the ankle is an extremely effective way of helping to calm the bladder down. And it's so easy for anybody, once they're shown how to do it at home. So you're treating yourself, you're not having to go somewhere to have the treatment. It's always part of an overall treatment program. So you would be under a health professional guiding you along there, but you can take the machine home and use it yourself at home. And there's no side effects, which is a great thing, because a lot of our other treatments for overactive bladder, a lot of the medications do have quite significant side effects. And, the stats show us that a lot of people cease taking those medications because of the side effects. So overall, it does need to be part of a treatment. It's not a standalone treatment, but it can be part of that treatment management program for people at home.
Yeah, and I've personally used it with patients as well, and it has shown to be such an empowering modality for folks to travel with, to help reorganize that neural communication pathway and ultimately not need to use it anymore. For a lot of the cases, especially with bladder urgency or even bladder pain, which I know we're not predominantly talking about, but I'd love for you, Fiona, to share what you know about the use of this particular modality also with bladder pain.
There's less actual research on bladder pain with it, but it's pain itself is we can use TENS quite successfully for treatment. So it's just applying the principles of using it to the particular area of pain. So and likewise, I've had really good success using TENS for bladder pain, again as part of the treatment program, but we can certainly use it on the pathways like around the sacrum. Some people actually get quite good results if we use it over the bladder at the front and some electrodes on the lower spine at the back. So any form of pelvic pain, we have got a lot of research on pelvic pain to do with painful periods, etc. And as we know, we often get bladder pain along with that sort of pain. So yeah, it can definitely be used very successfully with bladder pain syndrome.
Great. And I imagine that a lot of maybe listeners out there are saying, well, how would one, I guess, use it if they wanted to try it? Certainly getting the advice of a qualified provider and practitioner to dose appropriately, because the dosing, I think, is from what I understand, is certainly should be individualized to the patient and use and guidance and so forth. But there are a lot of over-the-counter TENS units, and I'm not sure if you have favorites or preferences as far as if someone is going to invest in a TENS unit, what does that look like as well? So I think that was a mouthful. That I just asked you right there. I apologize.
Yeah, that's okay. I think it's a little bit different because I think over in the States you need to have a script. Is that correct?
Correct.
So my experience here is that yes, we can go to a website and order one, or go to the pharmacy and order one. So whenever my suggestion if someone's buying a machine is to make sure that it's one that you can actually adjust the parameters on, as in changing the hertz or the pulse width, etc. Because there are a lot of them on the market that have a multitude of preset programs, and you might think, well, that's a great machine because it's got 15 different programs on it, but they're not always appropriate clinically. So you are better off getting one that you can adjust. And there's, without sort of promoting a particular brand, what you would need to, you can either get a digital machine like this one, which allows you to have really close control of your parameters. So you can change the hertz and the pulse width. And also when you're doing your intensity with the plus and minus buttons here, you're going up in increments of 1 milliamp, whereas a lot of the presets can sort of jump in like increments of 5 or so, which can be a little bit too much. The other type of machine you can get is what we call a digital machine. So these look more like this, where you're actually just turning the dials. These are always a lot cheaper option, but you're not quite as accurate with getting your parameters like the hertz and the frequency and the pulse rates on there. But they're for things like overactive bladder, they're perfectly functional. So, and these are fully adjustable, as are some of the digital machines. So just checking that you can actually adjust those parameters would be the best option or best advice I could give.
Right. No, that's perfect, because it should be, as you said, dose dependent and just based on that person's clinical presentations and goals and so forth, because it's going to vary from person to person. So a lot of folks will ask, well, what's the protocol? What's the protocol? And they want like a cut and dry answer, one size fits all. And, we're here saying it's not that simple, because we're embracing our complexity, but also the best approach is the individualized approach under the guidance of a qualified professional.
There are a range of if you want to call it a protocol to use for pain or for overactive bladder, but you need to be able to adjust it within that range.
Yeah. And would you feel comfortable to share what those ranges would be? if anyone was interested?
Well, absolutely. For what we generally use for overactive bladder, it's 10 hertz at a 200 pulse width, and you take it as high as you comfortably can. So there should be a strong sensation through the electrodes, which if we're doing TTNS will be around the ankle. And you can check that you're on the tibial nerve by turning it up. And if you start to get some toe movement, you know that you're on the right nerve pathway, or some strong sensation down to the toes. You then drop it back a little bit just so it's comfortable, so you haven't got, a toe cramp happening whilst you're treating. And it should be about 30 minutes at a time. And the research goes from once a day to once a week. But what the trend now is that if the more frequently you do it, the quicker you're going to get a response. So I would always start someone on a daily regime and then cut back down to every second day as things improve, and slowly wean off it. With pain, there's two options. You either go very low frequency, around the 1 to 4 hertz, or you go into the high frequency from 80 to 150 hertz. Two completely different pathways, but as far as pain relief goes, but generally you will find more effect using the higher range. So something from 80 plus, anywhere from 80 to 150 hertz. So if you trial the different hertz through that range and just see what works best for you.
Awesome. Thank you. What a gift to share that information, that people are
It's not a protocol.
Right. Exactly. Right. Exactly. Not a protocol, guidelines, but certainly should be taken into account individually by a case by case basis. So Fiona, there's this other, neuromuscular electrical stimulation, because there's various terms floating around as far as electrical stimulation. So can we clarify for folks, like TENS versus neuromuscular electrical stimulation, and when would you use that versus TENS?
Okay. It probably should, a better term is neuromodulation to cover the whole lot. But electrical stimulation, so probably a better term overall is neuromodulation. So that's what encompasses all of it. And yes, there are different terms. Electrical stimulation will sometimes cover NMES and TENS. So basically the difference is TENS is used continuously. So we're either using it as a very low frequency or a high frequency, and it's a constant sensation, and it's aimed at the sensory nerves. So we're trying to either reduce pain or reduce irritation of organs like the bladder. When we're looking at NMES, or neuromuscular electrical stimulation, we're aiming at the motor unit. So we're aiming to cause a muscle contraction. And that has to be done with what we call a work rest. So it has to be contracting or working, and then there has to be a rest period to allow the muscle to relax. That is then used in a very specific range, roughly 20 to 50 hertz, because that's the hertz range that the motor units that cause contraction in muscles will work. So we're trying to artificially contract muscle. Now, there may be some people out there who say, but you can get a contraction above 50. Yes, you can. But clinically, we don't use it because it's very uncomfortable and it causes the muscles to fatigue very quickly. So ideally, we're in that 20 to 50 hertz range, and we're aiming to get a muscle contraction. So that would be for someone who has some weakness of a muscle somewhere in the body. When we're talking pelvic health, of course, we're talking the pelvic floor muscles. So we can use NMES to help stimulate muscle contractions of the pelvic floor to help strengthen it.
Awesome. Wonderful. Thank you for that very clear definition of what that is compared to TENS and when someone would and would not use it. Now, what in both of those situations, when would these types of treatments be contraindicated or not recommended?
Well, there's a whole list of contraindications or precautions, but basically you need to have sensation in the area to be able to use TENS. Red flags have to have been, so I wouldn't recommend that someone without the backing of a health professional and a diagnosis, I wouldn't recommend to go out and actually buy a machine, particularly to be doing pelvic floor muscle strengthening.
Right.
But because you know there are some conditions, like particularly if there's cancer in the area, there's still a precaution, and there's a lot of other conditions that would preclude you from using it. So you it should be used under the guidance of a health professional who will make that call for you.
Right, exactly. Yes. Thank you so much for that. So Fiona, in the physiotherapy, physical therapy world, modalities like TENS have been kind of put on the back burner, so to speak. Like we are not highlighting those types of modalities because it's like the extreme of that's what we used to do and that's all we did to, oh no, we're not doing that because there's no effectiveness in TENS. But the research is showing us, especially in neuromodulation with pain and also what you just described with urinary urgency, overactive bladder, and incontinence, that these modalities do have some merit. And to walk us through kind of, you know, what needs to happen for us to kind of start to take these modalities back on the table again and have this as a viable treatment option for patients.
I think I absolutely agree. The pendulum has swung. Like I graduated, I'm giving away my age here. I graduated in 1984, and we used to use a lot of electrotherapy modalities back then, and probably overused back in those days. And then the pendulum swung, and nobody used them at all. And I think it's starting to settle where it should be now. And in fact, that's one of the reasons that I created the courses that I teach, because I was constantly being asked, how do we use it? What's the theory behind it? Because people weren't getting that training anymore. And, the research has improved so much over the years. And we've seen, particularly with neuromodulation, with the opioid crisis and, the research into alternatives has just exploded in recent years. And the research is being done in a much better way, I guess is probably the best way to describe it. So it's really up to us with with looking at the research and seeing that it works and speaking to our colleagues, teaching our colleagues that it can be used. It's not the be all and end all. It's certainly, any neuromodulation should be an adjunctive treatment, but it's very effective and can be used as a self-management, which I think is very empowering to patients as well. And it's I find when I speak at medical conferences on the topic, particularly for OAB, a lot of my medical colleagues, the urologists, urogynecologists, aren't aware that TENS can be used as an alternative. So I see that as one of my roles, is to educate. And I always get a great response when I speak on the topic, because I thought, wow, we can give this a try. And then I get contacted and, they ask me how to go about it. Because at the end of the day, we're all our patients are in our best interest. So we're looking for the best way to give them alternative treatments.
Right, exactly. And to that topic of treatments and expectations, when people are reinstituting neuromodulation in this way with the electromodalities, as far as our expectations of outcomes, how long should we give something a go before, I don't know, not tossing the baby out with the bathwater, so to speak, but saying, it's not working? Because I feel like something like this, as far as modulating the nervous system, is going to take some time. So what has the research shown us as far as expectations around how long should we start to see change?
That depends what modality and what you're treating. So, but definitely, if you were looking at muscle strength, you really need to give it a good sort of 16 weeks, 12 to 16 weeks, going by the research, which is what you would be doing if you were doing muscle training anyway. When we're looking at things like overactive bladder, what we found when we did our review is that you should expect some result within a couple of weeks. Like a patient should be starting to notice that perhaps their episodes are less intense or less frequent, but that you really need to give them a full sort of 12 weeks of treatment to be seeing a decent effect. But most people will start to see an effect within that couple of weeks. And where we're heading now with the research seems to be that, yes, more frequently will give you a quicker result. So, trying it every day, for example. So it's not that long, and it's certainly worth trying these techniques to see if we get an effect. But just on that point, an outcome measure is really important because it's to track how you're going. It's very easy to hand a machine to a patient and say, see you in 4 weeks, and they will still have symptoms probably in that 4 weeks. So if you say, have you improved? Oh, no, I've still got some urgency. But they need something to compare to from the start. So if they had done a bladder diary or used an outcome measure of some sort, we can then look back and go, oh, but look, the trend is, over each week, you've reduced the number of episodes or the intensity of that frequency. So I think that's an important point to make. We do need to track these changes so that the patient themselves can actually see, yes, there's been an improvement. It's easy yourself if you've been in pain, for example, for a while, and it's very hard to look back and go, oh, is it different than it was a month ago when you still got pain now? So I think those outcome measures are very important.
A very good point that you're bringing up. That those tracking that progress is so helpful for people to stay motivated with the treatment too.
Oh, absolutely. Yeah.
Both patient and clinician to say, what we're doing is actually making steps in the positive direction, and that it is making change, and to stick with it. Gives you the gumption to stick with a process, because often we if we're dealing with something and we're in the storm, it's very hard to see something, even those small changes that might be happening. It's just not as obvious to us because we are the person experiencing it, right? So I think having some, I would say, objective evidence where you're logging the bladder diary, for example, is something very easy to do for patients to just log their symptoms, start of treatment, and notice that. And so for the clinician as well, and then those formal outcome measures that you were mentioning. So empowering, again, to put treatment in the hands of the patient, really under guidance, but really empowering them to see their successes.
And also understanding why they're doing the treatment is so important to explain. This is what we're expecting. This is what we need to do, and to understand what to expect.
Right. Exactly. So if someone was to want to attempt to try this type of therapy for OAB, overactive bladder, or urinary urgency frequency, or bladder pain, and let's say they don't know kind of where to start, what would you recommend what advice would you give them if they're really interested in trying this? Who would they go to first? Where would they seek consult? Certainly we're physiotherapists, so I'm biased. Pelvic therapist, but
definitely, yeah. Look, well, certainly here in Australia, we're first point of contact. So just going and seeing the local pelvic floor or continence physio would be helpful. It really does depend and then if the problem appears to be something more significant, they can then refer on to the GP and medical team, urologist, etc. So I imagine over in the States, what your referral system would be to see your primary provider first. And even to, say that you've heard that this might work, would it be an option for me? Because sometimes your medical providers may not be fully aware of this particular method of treatment.
Exactly. In the States, it depends on which state you live in, whether you have direct access to a physio, like in Australia. So in my state, North Carolina, we are a direct access state, which means we are primary care, first care providers. So, but different states are not that way yet. So, and as you're saying, I think the biggest barrier is that primary care providers are not aware of this as a first line of treatment, or even urogynecological or urological care or medical providers are not aware that this can be a very viable treatment. So definitely connecting with a pelvic therapy provider who can guide and make referrals or connect with your doctor even to recommend such a treatment option. So yeah, I just encourage everyone not to let that be a barrier, and really to just speak up to be an advocate for your own self as a patient, as a person, as a consumer, as a knowledgeable consumer, and bringing these topics up to your providers to spread the word about other treatment options that are available other than medications or surgical interventions.
Absolutely. And that was one of the primary reasons we wrote the paper, because the other like side effects of medications and the more invasive treatments that we can go on to, at least if we've tried, lifestyle behavioral is always first line, and that's why it's good to connect with a provider who can, like a physical therapist or physio, who can teach you all of that. But adding in the TENS at that point, if it doesn't work, it's not going to work for everybody, but it works for a lot of people. But if it doesn't work, you've then still got those other options, the more invasive ones up the sleeve, to move on to, rather than trying and failing with those and coming back to try something that's a little quite simple.
Right. And I can imagine doing the backwards maneuver might be pose for more challenges with these types of modalities or conservative treatment after the fact. Not that it's impossible, but I imagine, I'm not sure what your experience is. I'm not entirely sure what that looks like, that path might look like if we went down that route of surgical intervention and then tried the more conservative, simple.
Yeah, it's more that they'll try things like medication and so forth. But interestingly, pretty much all of the research has been done on refractory OAB.
Wow.
So they've tried things like medication. So they go, let's use that patient cohort to do the research on. So I'm really hanging for somebody to do it as a first line treatment, because we're still getting excellent results on refractory OAB. So, my big thing is, would they be refractory if we had tried the TENS before we got to that point? So that's what excites me, if we're going to sort of head down that pathway. And anecdotally, absolutely, it does work, and prevent people from, getting to that very chronic stage.
Well, that's so hopeful. I had no idea that most of that research is just on refractory overactive bladder. That's yes. What a good point you bring. Like, what would the outcome be if we just started this sooner than later and kept it simple?
And can I just say there too, the alternative is what we call percutaneous tibial nerve stimulation. So it's doing the same thing, but instead of electrodes on the surface of the skin, it's a needle that's put into through the skin to sit next to the tibial nerve. That has to be done by a medical team. It's done by the urologist, urogynecologists, etc. It's invasive. You go once a week for 12 weeks. It is very effective. But you have to go through that whole process, and it's expensive as well. So what they're seeing now is that there've been quite a few studies that have shown there's equal efficacy of doing it through the skin or with a needle. So again, if we can, treat a lot of people with it transcutaneously, they can do it themselves at home. Then if that doesn't work, they've then got that option to move on to PTNS. So if you're listening and you go to a provider and they say, we'll just do PTNS, that's fine if that's the option that you choose. But there is the option of doing it yourself at home, which is less side effects, cheaper, easier for you to do, and you can use it as ongoing maintenance. So that's just a slight, another option there, but just to be aware of the differences.
Thank you for that clarification. That is so important, because you're right. Access to care, equally effective, and can be done at home, less time needed to go to doctors, etc. So, wow, again, so empowering, very hopeful. I feel like all roads lead to a pelvic therapist, because we're the ones that are, I hate to say it, but we're the ones that are really advocates. Not biased at all, not at all. But see, really, I mean, we are primary educators in this field, and yes, you may go to a medical provider, a doctor, but they are not aware, as you're saying. That's the biggest challenge, is they're just not aware that these other options are as effective and just as viable and hold merit than maybe some of these other invasive and more costly and time-consuming options.
And also 9 times out of 10, certainly here, if someone goes via their GP or the urologist or urogyne, they refer them to us as a start anyway, before they do go on to the more invasive ones. So that's my experience, in my little part of the world here.
Yeah. I have mixed reviews about that here in the States. I still hear that there's a lack of, yes, here's the first line of treatment, see a pelvic therapist. I'm hearing that more often, but still not as much as it I think it should be. Yeah, unfortunately, especially with pain. Sadly, it's still several years is the stat before people actually get access to providers like ourselves for pain care for pelvic pain. So yes, we're working on it one patient at a time. Yeah. And by just doing this episode, I think is very empowering and educating consumers and people about their options and sharing that with health professionals and their friends and family and colleagues. So thank you so much, Fiona. I really appreciate you sharing your knowledge and your wisdom on the topic. Any new ventures up your horizon, adventures professionally or personally?
Personally, I'm about to sell we're selling our house and downsizing. Our children have moved out. Professionally, I've got a couple more courses that are under production at the moment for health professionals. So, yes, and we've always expanding our website, which includes your book now. We have Susie's book here down under on our website. So.
Thank you.
Very excited about that. So, yes, and I'm just looking forward to hopefully the world getting back to a little bit normality and being able to go to conferences and run courses face to face again, and being with people.
Yeah, I agree, Fiona. And thank you for that humble shout out for the book. Can you tell the listeners and the viewers out there the name of your website and maybe yours, if you're on, I think you are on social media as well, on Instagram, at least that's where I'm at.
Yeah, so the website is pelvicfloorexercise.com.au, and we're based in, as you can tell by my accent, Australia. I have my Facebook is Pelvic Floor Exercise, and my Instagram is Pelvic Floor Exercise. So it's all pretty much the same theme there. So we sell products to the general public and health professionals to do with pelvic floor rehab.
Awesome. And the courses, for clarification, are for health professionals. Is that correct?
Yes, my courses are for health professionals. Yeah.
Okay, wonderful. And any teaser about what's brewing? Do you want to throw out a teaser for us? I'm very curious, but no pressure.
No, that's okay. This is for vaginal weights is my next one. So the draft is done. I've just got to have some dedicated time to start recording it. So that'll be another sort of standalone short course on the clinical use of vaginal weights.
Awesome.
I'm excited about because there's some great research that seems to have been ignored from the sort of the 80s and the 90s. Yeah, it's very interesting when you look at it.
I love it that you're bringing back these oldies but goodies, should I say that, like the research, the modalities that we have been here for a very long time and have sort of kind of, again, been put on the back burner. But now that we're understanding more about how they're being used and have better research, as you say, that they're showing to be more promising than we once thought they were. So,
but it's understanding. My big thing is it's understanding how to use it properly.
Right.
So I get asked all the time, what's a protocol for strengthening the pelvic floor? But if you understand the principles of neuromodulation, then you can work that out and adjust it for the individual. And that, to me, that's crucial.
Yes. Oh, well said. Great points. Thank you so much, Fiona. Again, really appreciate your time. Being here today, and I look forward to connecting you with the rest of the world. And all of the links that you've shared, your website, will definitely be putting that in the show notes for folks, and in the description on YouTube. So please check that out. So thank you again, Fiona. Really appreciate it. And for all of our and for all of our listeners out there and viewers, thank you so much. In loving wellness for your pelvis, This is Dr. Susie. Until next time.
Thanks for listening to today's episode. Be sure to head on over to drsuzyg.com where you can get more information, show notes, and related articles on today's topic. Also, if you like what you're hearing, head on over to iTunes, subscribe to the podcast, and leave us a rating and review. We'd love to hear feedback. Thanks again.